Hi, my name is Dr. Richard Burns, and I'm making a video at the request of Dr. Omar Almaty, who has asked me to share with you some of my techniques for treatment of temporomandibular joint disease. I've been practicing orthodontics for the past 33 years, and during that time I've been heavily engaged with treatment of TM joint dysfunction. During that time, I've developed some techniques and tips for dealing with this condition, which, as you might agree, is very difficult to deal with. I have treated in that period of time between 1,000 and 2,000 TM joint patients, and I believe very successfully. So I would like to share with you some of these things that I've learned over the years. During my 33 years, I held a faculty position at The Ohio State University for about 10 years, which is where I met Dr. Almaty, where I had the pleasure of being able to teach him. And in addition to treating the residents biomechanically based mechanotherapy in orthodontics, I also try to share with them some of the techniques that I have used in my office for treating TM joint disease. With this in mind, I have made a couple of videos, and I'd like to show you the construction of the appliance and also how to adjust the appliance, which is actually very critical to getting the desired outcome. A little bit about my philosophy on treatment of TM joint disease. I'm basically vehemently opposed to what might be referred to as the nathological approach to this condition, where the condyles are guided or seated into their upwardmost and superiormost positions within the articular fossa. In my opinion, this is frequently, if not almost always, a pathological condition in that it is distracted out of its physiologic normal range. Instead, I believe the condylar position within the articular fossa is determined by an equilibrium of several forces, including ligamental attachments, muscular insertions, and not to mention fluid pressure within the articular joint, with the articular apparatus. It is my philosophy then that the best approach to dealing with this condition is simply to unload the joint by virtue of using intraocclusal splint therapy. The goal of this is simply to reduce the forces which have, in my view, led to condylar distraction within the articular fossa and allow it to reassume its physiologic position based on that equilibrium of forces that are applied to it. And more often than not, I find that in the course of splint therapy, the condyles move downward and forward. And as this occurs, it's amazing because patients will experience fewer painful symptoms and, in fact, experience less incidence of clicking. In some cases, I have actually treated patients who've had year-long episodes of clicking, and after the splint therapy, the clicking simply goes away. I would view this as a recapture of the articular disc by virtue of allowing the condyle to reorient into what I refer to as physiologic CR. And with these thoughts in mind, I would just like to share with you these videos, which you will hopefully find helpful. I'd like to start with the construction of what I refer to as the anterior bite ramp. But before getting too far into that, I'd like to comment first on the base plate acrylic that I'm using. It's simply 60 thousandths Essex thermoform material that you can fabricate either on an Essex machine or a simple vacuum machine, BioStar, whatever you prefer. You don't want it too tight because if it creates a lot of suction like some BioStars, then the fit is excessively tight when it goes onto the patient's teeth. At this point, I'm mixing up some jet acrylic. I like the clear jet acrylic because I feel it's more resistant to wear than other standard acrylics like retainer or denture acrylic. And at this point, I'm mixing it up into a consistency where it has some stiffness to it, where it will stay on the end of the spatula without dripping off. And I'm wetting now the anterior portion of the base plate. It's important you do this because if you don't, when you add the jet acrylic, it may not adhere completely to the base plate. So here I am scooping it out of the cup. I'll put it right on the midline and then use my thumb and forefinger to simply form this into a wedge shape around the anterior arch form. It's also important that you wet your fingers slightly. If you don't, it's going to stick to your fingers and make kind of a mess. So I've found that just a little bit of water keeps that from happening. The shape of this is, once again, it's a wedge. It's pretty much vertical on the labial surface and about a 45-degree angle on the lingual surface. Since I'm kind of an auto car enthusiast, I would compare it to the banked turn of a NASCAR racetrack. And once this has fully cured and set up, we'll go to the posterior aspect of the splint, which I personally add separately. I don't like to do the entire arch initially because I want to use the anterior bite ramp to establish the vertical. So when I place this in the patient's mouth initially, which I didn't show and I apologize, I place the base plate as it is currently on the table in the patient's mouth to determine the posterior vertical dimension. What I like to see is the lower incisors contacting the lingual portion of the anterior bite ramp and leaving about 2 millimeters of clearance between the second molars. There's nothing significant about this measurement. It's simply a compromise between patient comfort and giving you some material to adjust. So I have found that about 2 millimeters is pretty much an ideal thickness or spacing posteriorly. Once again, as I did for the anterior bite ramp, I'm simply mixing up my jet acrylic to a fairly stiff consistency. Once again, wetting the base plate. It's important to do this because the jet acrylic does not adhere as well to the Essex material if you don't do this. So it needs to be a little tacky. So once you get the right consistency of the jet acrylic, I kind of divide it in half within the cup and then scoop half of that onto one side of the splint. And here we go. Kind of sliding it on, and now once again using my thumb and forefinger to shape it into a block essentially, and trying to blend it into the anterior bite ramp portion to make kind of a smooth transition between the cured and the uncured acrylic at this point. And it's also important that you put a little acrylic between that uncured and cured portion of the acrylic, because again, it helps to bond those two together. And once again, wetting the other side just one more time and applying the other half of the jet acrylic. It's important you work pretty quickly because you want to have this material fairly soft, because I'm going to put this in the patient's mouth and they're going to make imprints into the soft acrylic. So if you wait too long and the acrylic sets up too much, then of course that doesn't happen as well. And finally, and it's not shown very well here, and I apologize for that, I'm just putting a little bit of monomer between the uncured acrylic and the Essex base plate, just to let the monomer kind of capillary in between the two, once again ensuring that those two bond together well. And there it is. Now, it's still soft. I'm putting it in the patient's mouth. It's important that you develop a technique for not smashing the soft part of the acrylic, because once again, the posterior acrylic here is soft. The anterior portion is hard. So I'm pushing on the sides of the base plate, and as you can see, I'm not pushing at all on the soft part of the acrylic for the posterior teeth. Now, this is very important. Getting your patient to relax their mandible. I call this the random jaw jiggle. I put my fingernail on the lower central incisors and train the patients to relax their mandible, and I'm using a random movement here so that they can't track me. And after doing that, after you can get the patient to relax, you simply manipulate the mandible until the lower incisors hit the hard base plate acrylic, and there you have the imprints posteriorly. Allow the splint to cure fully, of course. I use pencil marks at the very depth of the cusp tip indentations, and then grind the acrylic down until, as you can see right here, I'm just barely removing the little pencil mark right there. And that gives you a relatively accurate approximation of where the height of that cusp tip was. I want the acrylic to be totally flat between the contacts. I don't want any indentations. I don't want the teeth to find a hole, if you will, to find a habitual position. I want the mandible to be able to move freely whichever way it wants to go, laterally, anteriorly, whichever direction, based on the reorientation of the condyle within the articular fossa. I'm very big on using AccuFilm. It's the most accurate articulating paper that I have ever seen or used. There are probably some similar products, but I think this is kind of the gold standard. Use 2 Miller forceps, and it takes a little practice, but you can use the 2 Miller forceps together, which I'll show you in just a moment. This now is fully cured. I've ground it so that I've just barely removed the pencil marks. And now I'm going to insert 2 Miller forceps holding one hand, and then once again use my random jaw jiggle technique and literally bang the lower teeth lightly against the upper splint and make the marks.
It's okay. It's silent. You can't.
And here we have just the first adjustment. It's close, but certainly not completely accurate. Grind the high spots. We're simply grinding down high spots here and trying to get even contact from approximately the second molars to the first bicuspids and the cuspids if they're in the arch form and in good alignment. This would be a second adjustment, doing the same thing over and over again until we get approximately the occlusion that I want. Once again, lower, thumbnail on the lower central incisor seems to be helpful for helping the patients relax their mandible and to get that nice hinged movement, which in my view is not just hinged, but it's hinged and translatory. Once again, adjusting the high points, and as the more adjustments you get, the more balanced contact you will obviously get between the second molar and the first bicuspid. Back in the mouth. And once again with the 2 Miller forceps and the thumbnail on the lower incisor. Getting the mandible to relax, gently hitting the lower teeth against the upper acrylic to make the imprints from the articulating paper.
That's pretty good.
And, there's pretty close. Probably can't see it in that picture, but I've got contact from the second molar to the first bicuspid, and I will then dismiss the patient with the splint, recommending that they wear that appliance 14 to 16 hours per day for 2 to 3 weeks, at which point I will see them again. In almost all cases, not all cases, but almost all cases, when they come back in 2 to 3 weeks, I will find that the mandible is, or I should say the lower teeth are contacting in the bicuspid area only and not in the molar areas. This, I believe, reflects condylar reorientation and mandibular reorientation. I simply readjust it for balanced contact from second molar to first bicuspid and send them away again 2 to 3 weeks, and repeat this over and over again to the point where the patient comes back and the marks have not changed significantly. When this occurs, and it may take 3, 4, 5 adjustments for this to occur, when this happens, in my opinion, this is what I refer to as physiologic centric relation, which is an equilibrium position dictated by the interarticular joint pressure, fluid pressure, ligamental attachments, muscular attachments, and so forth. And it's not a forced position in any way, shape, or form.